One of the reasons I wanted to talk about this is that as an educator for at least 35 years, I've seen the system change and change and change. And as you've heard this morning from Ernie, and a lot of you know from personal experience, that training doctors has changed considerably. And a lot of the training of doctors has been taken out of our hands and is basically in the hands of people who probably don't have the experience of what it takes to know what a good doctor needs to know to be able to take care of patients appropriately. So I want to start out with some of the history of where some of these regulations on training came from. So since the 1980s, increasing attention has been directed toward patient safety. The majority of early efforts were directed toward prevention of medication errors and errors by residents. The assumption was that medical errors were the result of long duty hours and inadequate supervision. This stimulated a number of studies, mainly derived from non-clinical situations, that cited fatigue, sleep deprivation as major contributors to medical errors, resident safety, and an impediment to learning. Interestingly, there were few studies that compared the adverse effects in teaching versus non-teaching hospitals. Nor was much thought given to the quality of training for future doctors and its ultimate effect on the quality of patient care and patient safety, which of course extends well beyond the inpatient hospital setting. Recently, attention is being given to the electronic medical records, as you've heard some this morning, and it was designed as a means to improve patient safety and reduce the costs of care and actually increase the efficiency of physicians. There's been little attention paid to the role of the doctor-patient relationships, fragmentation of physician care, physician education and satisfaction. And recent regulations aimed at physician educators fail to take into account the effect that increases on time and the tenuous balance between the academic and teaching responsibilities versus the need to generate increased clinical income by clinician educators due to the continued decrease in funding for physician education. So essentially, these rules and regulations are passing increased costs that are associated with them, and they constitute basically an unfunded mandate. So while it's very good to say that you need more physician supervision of all the residents and you need a lot of additional teaching, the problem is that the people who are supposed to be doing the teaching, the people who are responsible for doing the teaching, now also have additional stresses placed on them. And the stress is basically you need to see more patients, you need to generate more RVUs in order to be able to generate your salary, which takes away time, of course, from teaching residents. So let's start out by talking about the history of some of these resident duty hour rules. As you all probably remember, in 1984, Libby Zion, who was an 18-year-old college student, died in a hospital in New York under the care of resident physicians. A grand jury was initiated and indicted the practice of allowing inexperienced and unsupervised residents to care for patients. They also noted the contribution of long duty hours. In 1989, New York State was the first state to enact regulations limiting resident duty hours. So this is the first study that I decided to talk about this morning, and this is a study by Howard et al., who compared the duty hour changes in New York after the initiation of their duty hour law, which was initially a state law, which was called Code 405. And what they found was they looked at mortality from congestive heart failure, acute myocardial infarction, and pneumonia. And this was a retrospective study. And they studied both teaching and non-teaching hospitals, which they used as a control, which is an important strength of this study. So the results of this study indicated that when looking at unadjusted mortality rates for the entities that they studied, they compared the mortality rates from 1988 versus 1991, which was after the enactment of Code 405. And they looked at both teaching and non-teaching hospitals. And what they found was that in both teaching and non-teaching hospitals, mortality decreased, which was actually quite good, suggesting that there were things going on even in non-teaching hospitals where residents were not taking care of patients and weren't affected by duty hours that apparently affected mortality. And the reason I'm showing this study is because there are a lot of studies in the literature and studies that were used as a basis for deriving these new duty hour rules for residents that used data from single hospital settings and didn't have controls. And had these single hospital settings, only teaching hospitals, been used, the conclusion would have been drawn that the shortening duty hours for residents clearly improved the mortality in the hospitals. So if you see in the very far right-hand column, which is this column over here, that there's a comparison of the odds ratios of death between the teaching hospitals and non-teaching hospitals for the respective entities that were studied. And you can see that there is no difference. So clearly in this case, enactment of Rule 405 could not be demonstrated specifically to make a difference in terms of patient mortality. So as things went on, the ACGME began to adopt duty hour requirements. And in 2003, the ACGME restricted duty hours for all specialties to 80 hours a week. And this was a significant decrease compared to what residents and interns were working before that. In 2008, the Institute of Medicine published a pamphlet called Resident Duty Hours, Enhancing Sleep Safety and Supervision. So I chose this article because it was one of the many articles in the literature that looked at the impact of the ACGME regulations on work hours for residents. But this was particularly done in a neurosurgical program. And one of the reasons I picked this is because I think one of the problems in medicine in the past for us is that internists, surgeons, and other subspecialties all have different practice settings, and they have different goals that they feel they need to achieve. I think in the terms of duty hours, this is one where I think the whole medical community looks like it's coalescing and with an understanding that some of these regulations may not be the best thing. And if anything, the largest complaints about the duty hours, the largest assessments that they're hurting training have come from surgical programs. Now this is a neurosurgical program, and what they did was they did 2 surveys. They distributed surveys to 160 neurosurgical chief residents and 140 neurosurgical program directors about their perceptions of the 80-hour work week as related to patient safety, training, surgical experience, and cognitive development. And then, after that, they submitted a second survey to determine what they thought the potential would be of the proposed further reduction in duty hours to a 56-hour work week in the same areas. So what they did was they, first of all, looked at exam scores and conference participation and compared them between 2002 and 2006. That's before and after shortened duty hours. They also did looked at senior residents and program directors whom they surveyed between February and May of 2008, again after the duty hour changes, but before the even more shortened duty hours. And then they looked at the USMLE Step 1 scores, which is an indicator of the quality of the applicants that they're obtaining. And they looked at those between 2000 and 2007. And then finally, they looked at written exam scores, which are like the in-service exams that are given to residents in all specialties, for second and third year residents in the ACGME accredited neurosurgical training programs between 2002 and 2006. So one of the first things that became obvious is that if you looked at residents who took that exam for credit, meaning that they took it for actual necessity to achieve board competence, that if you look between 2002 and 2006, you can see that there is a small but significant decrease in board score performance, despite the fact that duty hours had been reduced. And one of the reasons for reducing duty hours was to be that residents would have more time, be better rested, and able to study and get cognitive benefit from it. The next is they looked at the more junior residents, the younger people who took these as in-service exams. And again, if you look at the board scores from 2002 to 2006, you can see there's a significant fall in performance on in-service exams after the reduction in duty hours. Now, you might say that this was the result of a worsening applicant pool. We're just not getting as good trainees applying for neurosurgery. And so they looked at the USMLE scores, and what they found was that if anything, the USMLE scores increased in the applicant pool for the neurosurgical residents over the time between 1998 and 2008. So you certainly can't ascribe the change in performance on board scores to the decrease in quality of applicants. And finally, they wanted to see, did this reduction in duty hours allow their residents to do something more academically? So they looked at the number of abstracts presented by residents over those years from 2002 and 2007, and they looked at the number of residents who had abstracts accepted for presentation. And what they found was that not only didn't they improve, they actually looked like they decreased. So clearly, the duty hour reductions in these neurosurgical programs didn't accomplish what some of the aims were intended to be. Now, this is just the results of the surveys that were sent to I know it's not legible. This is the best I could do with the slide. But these were the surveys that were sent to both the chief residents and the program directors of the neurosurgery. And you can see that the chief residents are on this side, program directors are on this side, chief residents are on this side, and these are their perceptions of whether the new duty hour reductions resulted in improvement or worsening of their experience. And the green bars represent worsening. And you can see that for surgical experience, clearly, both the chief residents and the program directors felt that there was a definite worsening of the experience. For cognitive development, same story. For access to quality care for patients, they felt, again, these hours worsened that. And for restrictions and resident education, again, they felt that they were worse. So the conclusion from this study was that both the objective and subjective criteria that were looked at in this study indicated that changes in duty hours have negatively affected the neurosurgical resident education. And this is occurring despite the fact that the quality of incoming residents was actually increasing, as indicated by the USMLE scores. So I picked this study to look at because this is probably the best of all worlds. This is a study that was done by surveying residents in the Brigham and the Mass General hospitals. The reason I'm saying it's the best of all worlds is not because they're Boston hospitals and they have great reputations. It's because that a lot of the duty hour work came out of Harvard. And they had major input into the development of how the duty hours would work and how they could best implement them. And they recognized early on that if duty hours were reduced, in order to keep the resident experience, in order to make the resident experience better, one would have to make sure that the residents' experiences in the hospital, when the duty hours were reduced, were not resulting in increased stress and work during the time that they actually were in the institution. So they surveyed residents in the Brigham and the Mass General hospitals in 2003 and 2004. This is a year after the 2003 reduction in duty hours, so before and after. One of the strengths of this study was that they used programs in the same institutions which were not required to reduce duty hours at the same time as the controls. And the other thing about this study is that they clearly anticipated the need for additional residents and faculty and had funding to hire these additional personnel before the duty hours took effect. So they made preparations before duty hour reduction. They brought on increased personnel, they hired additional residents, and they hired mid-care providers. They were able to prevent this way additional work for all residents. So clearly this is the ideal situation. So if just reduction in duty hours and actually protected the residents, the question is, would it make a difference in certain parameters that were looked at? And this is, we're going to skip over this slide because it basically just shows, if you look at the first line, that they compared these to the reduced duty hours, and this is the same residents in the program where the duty hours weren't reduced. And you can see on this line, they clearly worked less in the reduced duty hour group, and that their time in the hospital was less, as you can see on this line. And the important thing I think you should look at is the time spent in direct patient care is less. Okay, as a consequence of this duty hour reduction, there is clearly a reduction in the time spent in patient care, direct patient care. So this reduction in duty hours takes residents and interns away from time spent in patient care. And we're going to talk about this theme as we go on. So then they asked these individuals what were their opinions about things that, issues that could cause mistakes. And they talked about working too many hours, poor handoffs. These were the categories they were asked to comment on. Caring for or admitting too many patients, inadequate supervision, cross coverage. And if you look on the right-hand side at the p-values, you can see that residents working too many hours were a constant complaint of the residents who did not reduce their duty hours, but actually were significantly better in terms of the reduced duty hour trainees. So they thought that the reduced hours were not as heavily responsible for causing errors. Poor handoffs didn't change, and so whether you had reduced duty hours or not handing off patients to covering residents properly was always perceived and still is perceived as one of the major causes for errors in hospitals. Admitting too many patients was not an issue either for the reduced or the not reduced duty hour residents, and inadequate supervision again did not prove to be significant, but cross-covering too many patients was. So they thought that reduction in duty hours and reduction in cross-covering patients was a significant factor in reducing medical errors. This was the perception of the residents responding to the survey. Now, when asked what was the likelihood of reporting safety-related events in the past week, the important thing to look at on this slide is the second group here. And you can see that those reporting greater than or equal to one medical error, near miss, adverse event due to a mistake in the past week, in both groups was looked at. And in the 2003 group, if you look at the reduced duty hours program, 32.9% of the residents felt that they had seen or would have reported one near miss or adverse event in the week prior. And the reason it was a week prior is because they wanted to make sure that memory wasn't an issue in terms of forgetting the adverse events. Now, after the duty hour reduction, you can see that although there seemed to be a perception that there were less medical errors witnessed or performed, that it was not significantly different from the group where the duty hours were not changed. So the conclusion from this is, despite everything done perfectly, as well as this duty hour reduction can occur, the number of residents that reported at least one medical error within the past week remained high in both study years. In 2003, 32.9% for the reduced duty hours, 26.3% in 2004. So it appears that reduction in duty hours didn't seem to accomplish in this study a major reduction in medical errors or adverse events. So the Institute of Medicine came out with another set of recommendations, and they wanted a further reduction in duty hours. They said that along with the reduction in duty hours, this was supposed to be accompanied by enhanced supervision of trainees, improved transitions of care, safety reporting, optimized workloads, and time for reflection. Okay? These are clearly recommendations that are coming out of institutions that have no idea what practically can be accomplished in the milieu in which we operate now. So if you want to set up a training program and include all of this, we need to change things considerably if this is ever going to happen. So in 2009, of course, because the Institute of Medicine recommended this based on very flimsy evidence, which I hope I'll show you on the last slides, that the ACGME National Congress set up a task force, and they heard testimony from 67 stakeholders in terms of patient care, including hospitals and hospital organizations, and including citizen organizations, who, by the way, uniformly are in favor of reduction of duty hours for all medical residents. And the rationale for that is evidence presented to them that truck drivers can't drive more than 8 hours because we're worried they're going to fall asleep and make mistakes. And airline pilots can't fly for more than 8 hours without a certain amount of rest. And I would submit to you that these are not comparable situations, that no residents, no interns are in hospitals unsupervised. There's systems of checks and balances that are set up for all of these things so that errors committed under those circumstances are different than a guy driving a truck falling asleep when there are no checks and balances. At any rate, the result of this study or this Congress was that standards were issued despite the evidence presented by program directors, from chief residents, from trainees themselves, all of whom had major reservations about whether or not these should occur. And they issued standards that were effective last year, actually, in July, that limited interns to 16 consecutive hours in the hospital or in the work situation, and senior residents to 24, and they allowed another 4 hours so they can transition care from people who they were handing off patients to. Now, the case for this, as I mentioned, were that residents working 24 hours versus 16 were cited in some studies as more likely to commit serious medical errors, to make diagnostic errors, to experience failures in attention, to sustain sharps injuries, and to be involved in motor vehicle accidents while driving home. And that shifts greater than 30 hours every fourth night were associated with worse working memory capacity, sleeplessness, and or sleepiness, and they could be affected as long as 3 to 4 days after. Now, those were the studies that were used to establish those were the selected studies that they used to establish the recommendations. But there were other studies present, and many studies found that equal daytime sleepiness was present whether residents worked 12 or 26 or 24 hours. That some studies found that in neurology residents, no cognitive performance deficits in sleep-deprived neurology residents were identifiable. And that the important thing about, I think, some of these studies is that they identified increased fatigue among interns that correlated not with the hours worked, but with perceived stress. And as you can imagine, interns faced with these problems in medical care for the first time are under much more stress seeing things than a resident is. And a second-year resident is under more stress than a third-year resident is. And a third-year resident is under more stress probably than an attending when faced with problems that people have not seen before. So I think one of the things to keep in mind is when structuring ways to change rotations so that mistakes aren't made, it may not be duty hours that are the answer. It may be the milieu in which the trainees are working. So because of this, limiting hours needs to be balanced with other requirements in working and learning environments, which I think is an important concept. Now, I'm not going to go through this whole slide. I'm just putting it up to show you that these are the new regulations as of 2011 for resident duty hours. And you can see that there are regulations for everything. They can't be here more than so many hours if they, and the problem with these recommendations are that if a program does not comply with these regulations in terms of duty hours, if they keep residents longer than what they're supposed to be there, or if residents decide to stay, they want to stay longer because they don't want to miss a didactic conference or something like that, the program can lose their ACGME accreditation and lose their residency and internship. And that's just the way it is. And now the milieu is such that they all get a day off during the week, they get one weekend day off, they leave at 12 o'clock if they're on the night before, so if they're in the middle of taking care of a patient, they need to walk out of the hospital at 12 o'clock based on these rules and hand the patient over. Now, the most recent study appears in the New England Journal of Medicine. That's this year, and they did a survey of resident duty hour regulations after the further reduction, which is the 2011 reduction in duty hour requirements. And they, as I mentioned, before the implementation of these duty hour requirements, 2 large national studies showed mixed feelings among program directors and residents about potential impact and the proposed changes. And they all worried about the negative effects on patient care of increased handoffs and loss of continuity of care, which is certainly present with these new duty hours, and the potentially impaired education and less preparation to assume the more senior supervisory roles. So traditionally, as you all know, in hospital training and in the training of doctors, The interns are supervised by senior residents, and senior residents have accumulated enough experience to adequately supervise these people and be able to lend their experience. When you're starting out with interns who have minimal experience, and then they're progressing to PGY2s and PGY3s, who are now supposed to supervise the incoming interns, it doesn't take much imagination to figure out that they are not prepared to assume those supervisory roles adequately. So this survey looked at 123 institutions in 41 states that agreed to participate, and the institutions had a very large number of residents, 26,000 residents across the range of subspecialties. And this is the importance, again, of it. It is not just medicine, it is not just surgery, it's across the range of subspecialties. And they got a 23% response rate. And if you look at this, you have to be careful when you're looking at this slide, because the headings change in terms of what the ratings are. So if you start with the top line, you can see in terms of safety, patient care, if you look at the percentage of respondents, the middle column is unchanged. The response would be there's no difference in safety and patient care. Your right-hand side will be better, and the left-hand side is worse. So what you can see is that when these residents were surveyed about their perceptions of safety of patient care, that almost 75% of them found them to be unchanged or worse after the duty hours implementation. Quality of resident education, 40% unchanged, 40% worse, only a much smaller percent better. How much rest I got? That was 50% unchanged, 30% of them got more rest, but 20% didn't, and those ones that didn't are the senior residents who are now taking over the duties of the interns. Somebody has to do it. Availability of supervision, there was basically no significant change. Preparation for more senior resident role, clearly almost 90% of the residents felt that it was worse. Work schedules, 43% of the residents found that work schedules were worse despite total reduction in duty hours. Quality of life for senior residents, 50% of them found that it was worse. So PGY2s and PGY3s felt this system was basically much worse for them. And the quality of life for interns, of course, 61% of them felt that it was better. Now, if you go down to the next one, you notice the headings change: disapprove, neutral, and approve. How do you feel about the what's your overall feeling about the 2011 regulations? And what's obvious here is that 48.4%, almost 50% of the residents disapprove of these regulations. Now, the total number of hours worked as compared to last year, you can see that there's not that much of a change in terms of total hours worked. It's the sequence in which they're worked that's different. So they're not staying as long at any one time, but they seem to be working, many of them, particularly the seniors, a fair number of hours. The number and frequency of handoffs in patient care this year, and this is the important thing because handoffs are clearly associated with, in almost all studies, with medical errors and errors in patient care. And you can see that, that there were an increased number of handoffs described by most of the residents. 72% of the residents felt that there were an increased number of handoffs after the new duty hour requirements. And senior residents taking on work of more juniors, obviously 65.5% of the senior residents felt that they had more work to take on because they were covering. So what's the conclusion? That by changing the quantity of hours worked and increasing supervision at teaching hospitals, the new regulations were proposed to improve three areas: patient care, resident education, and resident quality of life. And this survey shows that 48% of the residents, and this is surveys of a large number of residents all over the United States in multiple specialties, disapprove of the regulations, 2 times more disapprove than approve of them. So this can't be ascribed to all of us old codgers saying, we did it this way, you should do it, because it's better. These are the residents, the trainees themselves, who are supposedly benefiting from the reduction in duty hours, feeling that it's impacting them in ways that are less than desirable. And these, by the way, are echoed by all of the program directors that are responsible for training of these residents. So what's the reason for the dissatisfaction? That's many of the residents end up working the same number of hours with no change in the amount of rest. This is more difficult to figure out, and I think there's some things that have to be worked out in this, because I don't actually understand why it comes out this way. But there are worse schedules than last year, which diminishes the overall quality of life. That I understand, because senior residents have much more patient care and ward care as opposed to supervisory and academic time. Preparing residents for transitioning to more senior roles, it doesn't happen in this system. It actually impedes it. No significant increase in available supervision, and that is probably true. The number of people available to supervise them all the time is probably not going to be able to increase significantly, even though that's a desired component of the duty hour reduction. And the increased frequency of handoffs, that decreased continuity of patient care, is a major complaint of residents. These residents, these trainees nowadays, are unable to follow a patient from the time of admission to the time of discharge. They basically, one of them admits them, another one may prescribe the treatment, and another one is present to discharge them, and often that resident that admitted them never sees that patient again before they're discharged. And that's, as we heard this morning, about trying to develop continuity of care in all aspects of medicine in terms of providing not only patient safety, but satisfaction of doctors is absolutely critical, and this system is undermining that incredibly. So the reason I started, I've seen this happen in our program for a long time and hadn't really looked at the literature until preparing for this talk, so I was thinking, well, maybe our experience is different than others, but every time you talk to anybody, everybody feels the same way. I can tell you from in our program that there's clearly less contact with trainees, both rounding and in didactic sessions. You can hardly find 4 of them together at any one time to sit down and give a talk to. Somebody's going to clinic, somebody's off because their duty hours are gone, somebody has a day off, somebody was on the night before. So you can't even find them around to sit down and talk. And if you want to do it at a time when they're around, then you can't get patient care done. This makes evaluation of the trainees much more difficult because the time that we have to spend with them and be able to use to evaluate them is much reduced, and therefore the importance of evaluating them and finding weaknesses and pointing them out as they go through their training becomes less and less. And as I mentioned before, we already saw a decrease in in-service exam scores, and it's occurring in medicine programs across the subspecialties. As you saw in neurosurgery, it's happening in medicine too. And these scores we thought that we had a problem. When we saw our in-service board scores go down at our institution, we were thinking that we must be doing something wrong. We need to find out what's happening. But then when we looked at the scores all over the country, the same scores were going down all over the country. So we still had our position, which was relatively high in-service scores, but the whole curve moved down, which suggests to me that there is a real problem going on all over, not just at Wayne State University. Okay, and finally, as Ernie Yoder pointed out this morning, that one of the important things that is starting to be looked at now is competencies in terms of residencies. So all residents are now judged on 6 core competencies. And this was a survey of program directors in internal medicine, surgery, and pediatrics that occurred after the 2011 ACGME duty hours. It was done by the Mayo Clinic. And what they did was rated the implications of these changes in duty hours with respect to the specific core competencies that the residents were supposed to attain experience in. And they had, in addition, they added continuity of care, which is not a core competency, and they added resident fatigue. And the results of this study are depicted on this slide. And what this slide shows is that if you look at patient care, the black bars represent a decrease in patient care, or at least a feeling that patient care was not better. No change is the gray bar, and the white bar shows an increase. If you look at the core competencies now, medical knowledge, most of the program directors felt this was worse. That practice-based learning and improvement, they thought they weren't doing as well in that. Interpersonal and communication skills, again, thought they weren't doing as well in that. Professionalism, not as well. Systems-based practice, not as well. And continuity with hospitalized patients, clearly not as well because of the time reduction. And finally, resident fatigue, that is the only area where at least no change seemed to predominate. Now, this study I'm showing just to point out that there's a lot of literature in the field. None of the studies are really that good. Many of them are single institutional studies. They're not randomized controlled studies. And a lot of the data that's being quoted by the Institute of Medicine and the ACGME are taken from results of these kinds of studies, which none of us would accept in clinical practice in terms of taking care of a patient. None of us would accept this as sufficient evidence to use in changing therapy for medical care. Nevertheless, it seems to be good enough for changing programs in terms of educating doctors who are going to be participating in patient care. So what they did was they surveyed from 1998 to 2010 all the literature they could find in studies that looked at shift length, protected sleep time, and a night float system, which has been instituted in many institutions to accommodate the change in duty hours. And they tried to validate these to do meta-analyses by standardized techniques, and they found of these studies, 64 studies only met inclusion criteria. And of these that met inclusion criteria, the best that they could find, most were single group studies. That means single institutional studies, and they were cross-sectional, and they did a pre and post survey. Only 4 were randomized controlled studies, and only 5 were multi-institutional studies. And this was the results of their meta-analysis. And you can see that it does appear, on the basis of the best they were able to do, that serious medical errors were reduced. The one would represent no change. Anything to the left represents an improvement, and anything to the right represents that there is a lack of improvement. So if you look at radiologic diagnostic errors, they seem to be improved. If you look at patient mortality, anything that crosses the line is insignificant. So this bar represents no change in patient mortality. Some studies looked at 6-month mortality and found that there was a reduction in 6-month mortality after discharge from the hospital as a result of changes in hours. If you look at surgical complications, absolutely no change, right down the middle. If you look at inpatient mortality, no change. If you look at medication errors, however, it looks like there was some improvement in medication errors and preventable adverse events. Interestingly enough, if you look at cesarean section deliveries, they seem to increase. And the reason for this is that maybe, I don't know for sure the reason for it, but if you have a resident that's following somebody through labor and they're going to have to be walking out of the hospital, get the baby out before I leave. I don't know. I'm just thinking what it could be. I don't know what the patient satisfaction score is. I read the article again because I couldn't find it anyplace in the article. I have no idea what it means. So we're going to skip that. So what are the conclusions that these authors who carefully reviewed all of these studies came up with? That they found several studies that met most of the quality criteria, and these studies found decreased errors related to reduced shifts. They did not find any decrease in mortality, inpatient or surgical mortality. They, however, said caution needs to be used in interpreting this data because many of them did not measure all of the important outcomes that are responsible for patient safety, and one of those was handoffs. And clearly they said, based on the fact that most of these were uni-institutional, you cannot generalize from these studies and apply them to institutions all over. They may have been particular institutions that had particular characteristics. They could not assess publication bias. And traditionally in studies like this, you're not going to publish a study that comes out negative. You're more likely to publish a study where the results are what you intended to look for: improve patient care, improve mortality, less medication errors. So probably these studies are jaded by the fact that there is publication bias. Only 3 studies examined 16-hour shifts, and therefore they couldn't determine from any of these studies the optimum shift length. Despite this, the paucity of evidence that's present, the ACGME guidelines recommended 16-hour shifts for PGY1s. So the best you can do is say that you don't know where the evidence is for all of this happening. Unfortunately, it's happened. And what we are going to have to do as a physician group is carefully analyze the results of this and make sure that the studies are well done. That is the only way that things are going to improve in terms of what we think needs to be done in terms of resident education. Now, I want to just finish up with the electronic medical record. I mean, there is a whole body of literature on electronic medical records, but I picked this to talk about because Dr. Diane Levine in our institution with several of the residents actually did a study to look at the impact of our electronic medical record on resident training in particular. So everybody is aware of the fact that the EMR has potential to increase the efficacy and effectiveness of healthcare providers if it's used properly, if it's the right EMR. Chowdhury et al. Found that there was a positive impact on quality, efficiency, and cost of medical care, and that was published in the in the Annals of Internal Medicine in 2006. And then the use of the EMR was supposed to have, in some studies, improved quality and accessibility of health records, okay? Within the institution, it clearly improves the quality and accessibility of health records. Outside your own institution, outside your own realm of your own medical record, whether it does or not still is open to question. So in 2009, our institution implemented the EMR with level 6, stage 6 capabilities. This is the super deluxe electronic medical record. It's had modules added to it over the years so that now the H&P is on it, the progress notes are all done on it, the discharge summaries are all done on it, lab results are all on it, imaging studies can be imported to it, and you can view x-rays on it. The documentation from ancillary services are all on it, and the most recent addition is physician order entry. So now all orders that are written by physicians in the hospital have to be put into the electronic medical record. There is no paper documentation. So the study was done to see the impact of the use of this type of EMR on graduate education, because there have been no studies to show what the implications are in terms of resident time, resident training in the hospital setting is. And as I mentioned before, Dr. Levine and residents in our institution did this study to find the impact on residents' daily activities, time spent on the EMR, and on residents' reading and education. And the reason she decided to do this study is because all of us have the feeling that most of the time residents are spending inordinate amounts of time documenting on the electronic medical record. So what are the results? 73% of our residents spent greater than 2 hours in patient care daily, but 56% of the residents spent less than 2 hours taking care of patients in the hospital on a daily basis. The residents that spent the most time on the EMR tended to spend the least time in direct patient care. This wasn't significant, but the trend clearly was there. And I think if we had more numbers, it would probably indicate that it's true. The residents spending the most time on the electronic medical record during the duty hours spent the greatest time on the electronic medical record at home. So this doesn't end in the hospital. They are going home and doing their notes at home. And I am getting notes to have to attest to at 9 o'clock at night from many of these residents. Now, the purpose of these shortened duty hours was to let these residents go home, get some rest, and read. Okay, now what's happening is with the electronic medical record, it appears that many of the residents aren't able to complete their work on the record because of the shortened duty hours in the hospital, and they're taking this home, and this is what they're doing at home instead of doing what they're supposed to, and that's getting some cognitive information that they can use to interact with patients and improve their care. The 75% of the residents stayed at the hospital after duty hours. Okay, so in order to get their work done, they were staying after duty hours. If the ACGME found out about that, we wouldn't have a residency. International medical graduates spent more time after duty hours than the American medical graduates. And that may be an issue with computer facility. I don't know. I don't think I've actually noticed that to be different between them. Now, 82% of the residents read less than 45 minutes a day, regardless of their rotation or workload. So even if they were on a lighter rotation, it seems like they're still not reading. Some of this is electronic medical record, as you see, some of it's not. 23% of the residents spent greater than 2 hours on the EMR during work, and they spent less than 30 minutes reading versus 45% of the residents that spent less than 2 hours on the medical record. So if they were working less on the medical record in the hospital, they spent more time reading in the hospital about patients. 81% of the residents who spent more than 2 hours on the electronic medical record after work read less than 45 minutes, but 64% of them who spent less than an hour on the medical record read more. There was no significant difference in the time spent on the EMR during work by the primary care or non-primary care residents, but the residents who were on primary care services like internal medicine, like family practice, those residents spent more time on the EMR after duty hours. So they had more charting for some reason to do, well, not for some reason. They have, because of the nature of what they do, their charting is more extensive and they had to take more of it home. Okay, so this basically just shows the curves of what we have found in what I just related to you on the slides. You can see that the red line is time spent reading during the day, and that a significant number of residents, the majority of residents, spent less than an hour reading during the day. And the blue line is time spent on documenting on the electronic record during duty hours. And you can see that the majority of residents were spending almost between an hour and a half to 2 hours documenting on the medical record during their time in the hospital. And the time spent in direct patient care, there were about 60 of the residents responded they were spending between an hour and 2 hours on patient care, but there were significant numbers of residents who were spending less than an hour on patient care in the hospital, which is almost inconceivable when you think about what's supposed to be going on there. Okay? And then finally, after duty hours, the red line represents time reading, and you can see that the majority of residents are reading no more than 60 minutes, and the other is time spent on documentation, and that the majority of residents are spending an hour documenting in the medical record when they went home. This is a problem that's got to be addressed somehow. So the conclusions are that residents spend considerable time documenting on the electronic medical record before and after duty hours, as you've seen, and that they spent less time in direct patient care and in reading than in documenting on the medical record. So these residents are spending more time entering data, documenting their care on the medical record than they are in taking care of patients and reading, at least in direct patient care and reading. And that work after hours on the EMR use fell heavily on primary care. So what about other studies on the EMR? This is a study by Duque, who found that interns spent more than four times longer with physician order entry after implementation than, of the EMR. So the fact that they had to enter the orders into the computer is more time consuming. It may be more accurate because there's checks and balances when you put it down, but it definitely takes more time, so the price you pay is more time. Total time spent on EMR documentation increased greater than 2 times than with paper charts. This is not our institution, this is another one. And that Amazon found that the EMR and computerized order entry resulted in less physician rounding time spent in direct patient care. So what's physician rounding time like? Pushing an electronic medical record around, pulling up x-rays, looking at notes, checking things, but not in the patient's room, examining the patient, sitting with the patient and talking to them. And this clearly is felt to have an impact on the clinical core competencies. And Udge et al. Found that clinical rounds focused on computer-based information and were less interactive. So I think everybody is having similar experiences, and this is something we are clearly going to have to deal with. This is a striking statistic, that in 1989, a study that was done and published in Medical Teacher showed that, this was the pre-EMR age, that residents read an average of 8.7 hours a week. In the study done by Edson et al., also published in the same journal later, found that residents read less than 7 hours a week, and this was done in an institution with an EMR. So it does look that reading is going down. Whether this is attributable to the EMR or not, obviously, this is too simplistic to say that. It may be, well, there's lots of reasons for it I'm not going to get into. Okay, I'm going to end the talk here, but I just wanted to give you an example. I just pulled a chart note off the other day and copied what a progress note in the electronic medical record looks like with all of these things on it. This is a 3-page progress note of a patient visit. You can see there's all kinds of basic information, subjective, health, allergies, all of the medicines, all the stuff they've ever had, active, not active, problem lists that occur not from the problems of this visit, but the problems through their whole history of the time that they've been documented on the medical record. And then comes vital signs, the physical exam, which of by the way, can be cut and paste from a physical exam from the day before, and does happen, which is frightening. So this looks like this patient was thoroughly examined completely for all of these parameters every single day, but we have no way nobody would have any way of documenting that they actually were at the bedside and did it, because it's not handwritten as a separate physical exam. And then finally, the impression and the attestation by an attending physician. This is 4 pages of a single chart note for a single patient visit that day. And the other thing I would point out, which somebody pointed out to me, is that this note is synthesized over a 12-hour or over an 8-hour period. A lot of them start their notes in the morning, make rounds, add things to the notes after rounds, and the impressions are always made later in the day. So the note is not a point in time. It's almost like a synthesis of things that happened over. If you're trying to track down things that happened in the morning and you're looking at this note, this isn't truly a reflection of everything that happened in the morning, which I think is potentially a problem in terms of analyzing things and how things work. So let me just finish by saying that the intended goals of the 2003 and 2011 regs were to improve resident well-being, and I think everybody agrees that, at least for the interns, resident well-being seems to be better, but not necessarily for seniors. And this has occurred, however, at the expense of education. Many programs have been forced to decrease their elective rotations, decrease their teaching conference, decrease their clinical bedside teaching, and most importantly, resulting in more frequent patient handoffs, which everybody agrees has to do with a decrease in patient outcomes. So it would seem logical that if the time spent in the hospital and outpatient settings is limited, then residents would have to spend more time educating themselves outside the duty hours. Neither in our institutional studies or comparisons with other studies of residents' reading time is that happening. And I think that represents a huge problem for us, and something that we are clearly going to have to be actively involved in, especially those of us who know that you cannot take care of a patient without seeing them. You cannot take care of a patient without being there during their acute illness. You cannot do this by handing a patient off when you have to walk out at 12 o'clock and the patient is ill, and that no handoff, no matter how many studies you're going to see are done to improve patient handoffs, can transmit the gestalt that you have when you're sitting with a patient in the morning and you think something's wrong, but you don't know what it is for sure. How are you going to transmit that in a handoff to another resident who may be handing that patient off at midnight to another resident? There is no possible way that can happen, and you're going to see hundreds of studies now being done to improve handoffs and transitions, and they're not going to account for that, and they can't. And all of you who take care of patients know that that can't happen. Okay, I'm going to stop now. Thanks.